Let me say how much I wish I could be in person. It's lovely of you to give me a chance to join you virtually, but best of all to be in the room. So thank you for this chance, and I regret I'm not there in person. I think all of healthcare, including medication use, is, if it's properly done, it's co-produced, it's co-developed. Believe me, the patient, the family, they know more than we do about the medications and their effects, and we just don't ask them. We don't ask them at the level of narration and relationship that really makes a difference. So I think there's a whole frontier here, but it means tearing down the boundaries. It means that you're never done. The drug has a journey through time and space which we need to follow, and we need the help and wisdom of patients and families to do that. We need clinicians in the same room as the drug developers, and see this as an overall learning process. The fragmentation, the silos, the I'm done, now it's yours, that stands in our way. It's not the way to learn in the modern era. I have a very important story in my career about this, which is in cystic fibrosis. We had a problem. The Cystic Fibrosis Foundation was sitting on a lot of data. They knew the performance of, I think it was about 160 CF centers around the country. They were voluntarily contributing to the CF database. But under the charter, the data were anonymized, blinded. So you could see that center number 123 was doing fantastic at lung function preservation, let's say, but you couldn't find out who that center was. Why? Well, because there was a fear that if we unblinded, then the centers that perform well would tout it and use it for advertising, stealing market share, and the centers that were performing poorly would be injured somehow economically or reputationally. And so the rule was don't share. But that was inhibiting learning. Because if Center 123 was doing great on lung function and I wasn't, what an opportunity there is to go visit him and find out. So the project I'm talking about, we were invited, IHI and others, to come in and say, how can we get to knowledge, to learning? And in the room was Honor Page. Honor was on a board, I believe, of Cincinnati Children's Hospital Medical Center, and the mother of a child with cystic fibrosis, an adolescent girl. And she'd become involved in this. And I remember turning to Honor Page and said, Ms. Page, what do you think about this fear of sharing data? What would you tell the CEOs? And she said, I'd tell them that for my daughter, the clock is ticking. And it turned the room. You know, people started, oh, wait a minute. We got some duties here, and they override the tribalism. When you put the patient at the center and you say our job is to help them, then cultural barriers are narcissism. It's waste. It's self-indulgence. And yes, I know you have a culture, and I know I do too. But look, there's a person there, and their future, their well-being, their thriving, their lifespan depends on us. We're taking an enormous liberty when we let what we're calling culture lead us to close doors and not listen. Look, quality is all about cooperation. And that's because we need to learn to improve, and the learning, it courses through time and space. So yeah, with drugs and drug development, we're not done when the drug's improved. We're never done. Every individual patient is an opportunity to learn something we didn't know before. That's true, I think, in the world of drug development, because I think we really, especially now with big data available, artificial intelligence, machine learning, I think with proper data, we could learn so much about what medicines can do for whom, when, at a level of granularity never before achievable. That's just from the development side, but that doesn't end when it's improved. That's a commitment to ongoing learning. More than that, in the clinical world, when you use a medication on a patient, every single time it's a test. You're trying something out, and you may think you've been there, done that, and now you have the drug. No. What happened to Mrs. Jones? What happened at 3 o'clock and 4 o'clock and 5 o'clock? And what are the subtleties that she now knows that you don't? And I think that individualization, the N of one thinking in the use, not just of drugs, this applies to all interventions, all diagnostic modalities as well as therapies. It's uncharted territory. Every doctor is a researcher if she or he wants to be, because every patient provides a laboratory. moving a learning system forward is hard. It takes time and resources. People are so busy, but if you're going to follow a process over time and space, like what is this drug doing, you got to invest in that. And so we have to give continuous learning the dignity it deserves, represented in investment, not just attitudes. I think the key is what the New Digs project is doing right now. You got to be in the same room. The fragmentation kills us, and this is about people. And so I don't see a way to learn without being in relationship, and I don't think there's a way to be in relationship without building relationships. That's really hard in a stressed world where you can barely get through your day to say, now we got to go to somebody else's house and be a guest for a while. I think that requires some investment, that energy that we may feel we lack, but there's no other way. Once the relationships are there, then it's process. Then you have to figure out, well, how will we do this together? But it starts by being in the same room. Now, what can leaders do? Model the change. I mean, my mentor and friend, Paul Batalden, who helped found IHI, once showed me a diagram about leadership behaviors in pursuit of improvement. It was a flow diagram, but at the top box, he wrote the word curiosity. I said, Paul, what is that about? He said, curiosity. If the leader isn't evincing authentic curiosity, humility about what they know, then it's not going to go well. Well, if you're authentically curious, you leave your office, you leave your room, you leave your culture, and you go somewhere else. So I actually think leadership behaviors matter a lot. I do have a request for the New Digs effort. It has to do with aims. So IHI, in maybe 2007, 2008, we published the triple aim. That was the invention of two colleagues of mine, John Whittington, a doctor in Peoria, Illinois, and Tom Nolan, my mentor and one of the great scholars of improvement in the world. Tom and John had been working together, and I remember them coming in and saying, in the world of quality, aim is everything. You never improve by accident. You have to know what you're trying to get done. Maybe it's robbing a bank, but you have to know what you're trying to get done. Then you can improve process. He said, well, what are we trying to get done here? The whole world thing, all $3 trillion in the United States, all the pursuit of all these professions. And they said, well, it's a triple aim, a system of aims. Better care. So if you're in care, it goes well. The Institute of Medicine framework, safe, effective, patient-centered, timely, efficient, equitable, those 6 qualities, that's a better care. If you have your heart attack, safe, effective, patient-centered, timely, efficient, equitable care. But the heart attack came from somewhere, and we all know that isn't healthcare. Healthcare doesn't produce health. It's a repair shop. What produces health is elsewhere. It's nutrition and exercise and the environment, the air we breathe. It's social justice. It's fairness in society. It's racism or its absence. And if we want to work on well-being, we have to leave healthcare and work on the determinants. So there's a second set of, in the triple aim, better care, better health, but there's a third one, lower cost. At $3 trillion a year, this healthcare system in this country is confiscating resources, confiscating public resources from governments that need that money for housing and schools and roads and community well-being, and it's confiscating it from private sector actors, companies that want to be globally competitive, and workers, laborers who want to send their kids to college or go to a movie. And we don't have a right to it, and the evidence is very, very clear that of the $3 trillion we're spending in the U.S., $1 trillion is waste. It's pure waste, and I think that's an underestimate. We don't have a right to that. And Nolan and Whittington are right. Better care, better health, and lower cost. That's got to be our bogey. So I think we all have a role in this. I think part of the cooperative endeavor that we need right across the stakeholder groups, the stakeholders in this room at this conference, is the triple aim, including lower cost. I don't mean hand-waving about this. I mean lower cost. And I hope that in the pursuit of the New Digs project and the idea of building continuity, we put that aim fair and square in the center of the agenda. And I plead with the people that you're pulling together in this project to say out loud, American healthcare costs too much and it's confiscating money it shouldn't be using, and we need to return that money. Good news is we can do it, but only if we cooperate. So the ethos of New Digs, the idea we're going to get people together and work across boundaries, that's tonic to my soul if you guys are serious about it.